So there was one question from Mohamed Otman Hakami from the audience, and he asked, is there any comparison between the LENTIS Quantum and Acunex EDOF outcomes, please? And as I mentioned before, it's right in between a MA15 defocus curve and a spherical disfocus curve. Once again, thank you very much for the great overview. Wonderful session. Thanks, Sunil, for showing this and making very obvious how playful you can be and how you can individualize the process for patients. So are you doing this as well in your clinics, Ramin and Sunil? Perhaps, how do you translate this to your patients?
Yeah, so actually I think I have tried to address that in my talk, that I actually try to use a large variety of intraocular lenses, and we basically have experience in our center with all the major players. Most of the data that I presented were actually taken from our university. What I really find important is that I've also now attending these conferences now for many years. We are always speaking about these fancy intraocular lenses, but when we look at the numbers, how many of these lenses are at the end of the day really in our country implanted, we are always quite shocked to see that it's a very small number. So when we are talking about all these presbyopia correcting intraocular lenses, all of us, we are doing that already. I think that the new technology, and that is where EDOF and monofocal plus is really hitting, is that this is now the first time an option for a normal cataract surgeon who has never done any presbyopia treatment at all. You can at no cost for the patient, there are no photic phenomena, and there's no decrease in distance vision, implant this intraocular lens and then really appreciate how nice it is to treat presbyopia. And I'm sure that once these people have started, that the other presbyopia correcting intraocular lenses also will become more interesting for them.
So thank you very much for addressing this. That's why I tried to push you a little bit in that position. As you said, I think it's a real problem and a shame, kind of a shame, that those lenses are only 1% to 2% implanted in Germany. So can you give a clinical tip in pearl how you explain this to your patients, how you motivate your patients?
Yeah, actually, I would say, for example, with the monofocal plus lens, in my opinion, there's really no education required. You can tell your patient, if you are going for that monofocal plus lens, you will not have any side effects more than in monofocal lens. You will have one line, at least one line, better vision in the intermediate distance. And I would argue, even if a patient is not interested in spectacle independence, it's always good, to have one line more of intermediate visual acuity than to only achieve that with spectacles. And that's why I think, in my opinion, that's a no-brainer. You don't really have to convince anybody. You can simply throw out your traditional monofocal lenses and only implant monofocal plus, in my opinion. There are no downsides. There are really no diseases, which I would say, where I would not implant a monofocal plus lens. A trifocal lens, all that is different. We have to examine the eye very thoroughly, and if there are macular drusen, I would be very hesitant to go for a trifocal intraocular lens. With a monofocal plus lens, there's no such an issue. We are not losing significantly best distance corrected visual acuity, and therefore we can use that in such patients as well.
So Sunil, what is your message to those surgeons who don't use it yet? How can you motivate those doctors who are still a little bit hesitant?
You're crazy. I mean, it's my entire practice is word of mouth. We hardly market, and your patients are just so much happier. You ask your patient, do you want me to sort out your distance vision? This is cataract or refractive lens exchange. It's the same discussion. Do you want just your distance vision sorting, or do you want your distance and your near? I mean, think about it yourself. What are you going to give an answer to as the question? You always want both sorting. So in my practice, more than 90% will have an EDOF lens or a multifocal lens. there has to be a special reason for me to put in a monofocal lens. I just don't. I just don't see the need. So I think. So what's happened with my practice is people come to me because they know I will offer them special lenses, and it's grown my business. Whereas I know my colleagues who only use monofocal lenses, their business has remained static. So from a commercial viewpoint, you should do it.
Okay. There is another question by Mohamed Hakami, who wrote, is there any risk of neuroadaptation of a blended vision with the EDOF Acunex Vario as experienced? I think Sunil already made a good remark. When I started 10 years ago, I was very keen on dominant, non-dominant eye, making different tests to find it out. I did a contact lens wear trial. But nowadays, I don't do that at all anymore. All I do is I tell the patients up front, it will take 6 to 12 weeks. After 1 month with blended vision, you will not be happy. You will sit there and ask yourself, did I do the right decision? That's what I ask myself after 1 month. But after 6 to 12 months, you're through with it. It's a natural vision that is much nicer than with a trifocal IOL. That's what I experienced, that's what I'm telling my patients. So I don't think that the testing makes sense. It's the way how you guide your patients, and you do have to guide your patients, because if they're not happy over 1 month and they don't return and come back to you, they're like an unguided missile, because they tell everybody, it didn't work, blah, blah, blah. So what I do, I see them 1 month after surgery, 3 months after surgery, I reconfirm them, I try to solve the problems, and even every patient gets my private mobile number. So this is a very important part of the blended vision strategy.
Sorry, Detlev, I think it'd be interesting for people to hear your experience of your blended vision. I mean, we know it's laser, but how did you adapt?
Okay, it's stages. The first 2 days was like, it was a fancy vision because your right eye didn't see far. You really feel your eye. It's like a feeling in your eye. I had, when stepping down steps, I realized, oh, this is different. When driving a car, I thought I would see the car a little bit later. This was gone after 1 week. So going down steps, no problem. Seeing the car, no problem. But looking far, I still was like, I could feel the eye. It was not like I'm seeing worse, but I feel the eye. And my patients always said in those first months, the near eye is like a mud eye. I never understood what a mud eye is. But then I understood what a mud eye is. You don't only have a worse vision far, but you feel your eye. But if you reconfirm, and if you have a positive way to reconfirm your patients, then you get through that phase, and nowadays I'm so happy. Since 18 months, I never touched reading glasses anymore. And this is so comfortable. It's wonderful. So what is your opinion, Ramin? How do you guide those patients?
Yeah, so obviously I'm always in this. I always have to decide, whether I'm looking at a refractive lens candidate or a cataract patient. In my opinion, the cataract patients are quite easy to treat. I would say if they have very poor vision before surgery and you treat just their cataract, they are already happy. But still, I think that these days we should consider presbyopia as a disease, and we should also increase intermediate and near vision as much as we can. With the refractive lens exchange candidate, all that becomes a little bit different. The expectations are very high, and we have to achieve excellent vision in all distances. Otherwise, these patients will not be happy. Then there's one issue that we always have to discuss with our patients, and that are the side effects, and you have very nicely addressed that. I would say that there are certainly refractive lens exchange candidates which are tolerant to side effects. If I tell them about the side effects and they tell me I'm not driving a lot at night, my focus is really near vision, I still think that options are also good to implant lenses like trifocal lenses in such a candidate. But we also have to keep in mind that nowadays there are a lot of people driving a lot at night, and I think that in the last years it's not just visual acuity that has become important to our patients and to us. It's really visual quality, and I think that this is something that we have to take care now. We should not just look at visual acuity results, but we have to very strongly also focus on visual quality, and that's why I think that there's a lot of space for EDOF technology, because that is really the strong part of these lenses.
Mm-hmm.
Detlev, can I just add to that you know, particularly with the age group you're talking about for cataract surgery, one of the big problems with using trifocals or other multifocals, you know, you have to be absolutely sure they haven't got dry eye. You have to have an absolutely normal eye in other respects. So this lens is just very tolerant for any problem. So, you know, I automatically default to this lens if I feel they've got significant dry eye, which I can't control easily. Whereas I will not put in a trifocal or a multifocal in those patients. But as Ramin said, they have a little bit of a macular problem. They have a early epiretinal membrane. I mean, it doesn't matter what sort of pathology. There isn't a problem putting a lens like this in. So it opens up a whole new level of patients that you might use these lenses in.
There's a very interesting question, I think, from Detlev R.H. He asked, what is your lens of choice for mini monovision correction, and how do you choose from all the different options? Why I do like this question is because you very nicely understood what's the main point of EDOF technology. It is really treating our patients the best way in a very individual approach. And I personally always look at the side effects. So the first thing I ask my patients, what would you bother more if you need, for example, glasses for very small print reading, or if you would have photopic phenomena? So I at once know by asking a negative question, what do you tolerate? Because this is the moment when a patient comes back and costs you a lot of shared time, doesn't like you anymore, gives you a bad reputation otherwise. So I think the negative approach to ask what bothers you more, not to be able to read small print or having a halo and glare at nighttime, is an approach. Then how I differentiate between the different EDOF IOLs, the more tolerant the patient is, the more pragmatic it seems to me, the more I try to stretch the monovision. The more fearful, the more hesitant the patient is, the more I tend towards monovision. But that's my personal approach. Then Ramin and Sunil, what is your personal approach?
Yeah, I think that you suggested a very good approach, and that would be very similar to the one that I would take. I can only say that if you are starting with that technology, all these things regarding mini monovision are very interesting options, but I would really recommend in the beginning just target for emmetropia in both eyes and just experience what the monofocal plus just gives you in that regard. And once you're familiar with that, then you can start with the other options like mini monovision. And in my opinion, mini monovision is much easier to deliver to your patients and to practice than real monovision, because with real monovision, you are all aware of that, we sometimes really do not have the happy patients that we want to have.
I think, I mean, I agree with everything which has been said. It's you do need to discuss with the patient. So it's trying to gauge their level of acceptance and their personality, and the difficulty with all that is once in a while you'll get it wrong. So you know, because you all know that to the doctor the patient behaves differently to what they're like outside. So if you're using an EDOF lens, as long as they understand the expectations, there generally isn't any problem, because you're not going to have any side effects. You've just got a limitation of what you can achieve, which you can manage with other techniques, as we said.
Okay, then there's one question from Boon Jong Tan. What is the equivalent add for the quantum? I would guess, I think I have to answer this question, 0.75 to 0.10 diopters. Another question from Mohamed Hakami was experience of outcomes, hydrophilic or hydrophobic design. I think that's easy to answer. As always, hydrophobic does have less. And perhaps one of you wants to present the astonishing results of the FEMTIS regarding PCO.
Yeah, so actually yesterday we have had a talk where we talked about the FEMTIS IOL. So the FEMTIS is another innovation coming from Teleon, and I really like that option because we have been using the femtosecond laser for several years, but I would say that we have not really seen the advantages that this technology is bringing to us. And the FEMTIS IOL is now a lens that has 2 traditional haptics which are placed in the capsular bag, and it has 4 additional haptics that are then inserted into the capsulotomy, and that leads to great results in terms of rotation, in terms of tilt, and in terms of decentration. And I think if we are really talking about all these premium platforms, that this is an excellent option, because for such premium lenses we need no tilt, no decentration, and no rotation. And that's why I think that these type of lenses, which are really fixated in the capsulotomy, will rise the bar for future technologies.
But it does, certainly in my hands, just using the FEMTIS actually improved the uncorrected vision results and narrowed the range of results. So not a little bit, I mean, noticeably different. But with so many patients, I mean, I've never had so many patients bringing in presents. They were just so happy with their distance vision, and all we've done is, as Rowan said, taken away the tilt and changed the positioning of the lens.
Yeah, and you also asked about PCO. Yeah, we just published all 3 paper together where we also followed up the FEMTIS patients, and it's a follow-up of 12 months. Yeah, so this is certainly not enough to address the topic of PCO. But in the first in the first 12 months, there were more than 50% of the patients who had a PCO grade of 0 or 1, and the YAG laser rate was about 3%. Yeah, so PCO was certainly not a huge issue. This is something that a lot of people are afraid of. Yeah, when they are hearing about these lenses that are inserted in the capsulotomy, that this might go along with a huge risk of PCO, but that is not really the case. It's not what we are seeing in clinical practice.
Okay, then I think time is flying or flew by. Thanks to the great contribution from both of you. Thank you very much. Thank you very much, Teleon, for providing us with the freedom to speak freely and also talk about other IOLs and comparing this IOL. So I hope we could convince some or more doctors over the years of using this really excellent IOL technology to better treat our patients with a personal approach and without halo and glare, not to wear glasses anymore. Thank you very much. Thank you.